With my colleague Myra Stern, we both work as integrated respiratory physicians, which means we're able to contribute to the strategy, the leadership and the care of patients across the pathway. The patients population that we are aiming to provide care for are those who live in Haringey and Islington with respiratory disease. So that's a population of about 500,000 people. And I think we're moving more and more to thinking about the needs of the whole population rather than just the particular patients who present to clinic or are admitted to hospital. Because I work in a respiratory team, the people we are providing care for are those who are living with breathlessness. So this is about working to make the right diagnosis of the cause of their breathlessness and provide evidence-based treatment for their breathlessness. I think the underlying principle of how the team works, and we together lead a multidisciplinary team of nurses, physiotherapists, psychologists, quit smoking advisors, and most recently a pharmacist, is that what we want to do is to improve the outcomes and experience for people living with breathlessness at the lowest possible cost, which is how value's defined, and that's a very nice way of pulling together how what the priorities are for patients and clinicians and what the priorities are for commissioners. The way that we deliver the service is out of 3 sites. 2 are based in the community, 1 in Haringey and 1 in Islington, and also a hospital-based site which allows us to both in-reach into the hospital and connect and outreach into the community. The most innovative features of the service model include a number of things. I think the first is using the value framework to prioritise what we want to do and what we do in delivering patient care, which is outcomes divided by cost, and allows us to align what patients want with what clinicians want with what commissioners want. The second innovative thing has been prioritising evidence-based communication skills on the same level as evidence-based clinical care. So specifically thinking about how individuals work in teams and how we work with patients who have long-term conditions. So that's included having a psychologist in the team and prioritising behaviour change skills. So for example, motivational interviewing as being as important as some of the evidence-based clinical care. The third innovation has been a cultural change within the way that the team works, so that we've taken on quit smoking as a treatment as part of our work as clinicians, because we know there's an evidence base to do this, both in terms of the counselling skills to support patients to stop smoking and the prescribing of medication to help them. The final, I think really important innovation is that we've got on and used the commissioning incentives out there that allow us to drive change across the whole pathway. So we've used a local enhanced service in the community and a sequin in the trust to drive the same interventions in both COPD and in quit smoking as a treatment, which has meant that we've been able to have a step change in the way that we address those interventions. The biggest challenge in setting up a service that involves working across the pathway and in the community is how to align the commissioning incentives with the patient priorities and the clinical incentives, both in terms of what are the outcomes you want, what are the things being measured, and the timescale over which you're measuring them.